Okay, before we talk about CHF, we need to have a few definitions. We'll start with these on the board so I can erase them. I think I need this space later, okay? And these are just go with the definitions for now. Inotropic is the increased force of contraction. One of the problems with congestive heart failure, that we will learn, is that it stretches out the heart, these cells, these myocardial cells, it stretches it out where it becomes hypertrophic. It's a weird word. I don't use it very often, but it means it's enlarged. Okay, something that's hypertrophic, it's enlarged. Okay, well, with CHF, one of the problems is enlarged heart. You'll see this on the X-ray when you visit the hospital. These guys get an X-ray, and they're going to have this large heart, this big heart that covers the X-ray up. You go, wow, they have a big heart. They must be really nice. Okay, no, they have congestive heart failure. Okay, because the heart's supposed to be the size of your fist, correct? You've held that heart, so you know.
Except that one guy.
Yeah, except the big old fatty one, all right, or one that's stretched out due to CHF. So a problem with this is that it decreases the force of contraction. So here, when you give medicine with CHF, you give a positive inotropic drug, and I believe all these are positive. Okay, I can't think of any reason why they would be a negative. Except if you're trying to slow the heart rate down. A beta blocker would be a negative chronotropic drug. But inotropic increases the force of contraction. These definitions will make a lot more sense once we get into the explanation of congestive heart failure. Dronotropic increases the conduction rate through the AV node. So dronotropic increases the conduction rate through the AV node. Chrono time is increases the rate of the SA through the SA node, or increases the heart rate. So keep these in mind as we go through, okay? And we talk about congestive heart failure. CHF can either be acute, a quick onset, or it can be chronic. It falls into the COPDs that we'll pick up next week when we talk about emphysema and chronic bronchitis. Okay, it's over a period of time. That the heart, maybe the patient goes into failure over time. That's how my mother died, is congestive heart failure. She had CHF, and at the end of her time, she couldn't walk across over to Steve without stopping and taking breaths. She wore oxygen all the time, and so she had one of those walkers that she walked on, and she got about halfway somewhere, and she'd have to turn around and sit down. Okay? It was a pain in the rear to go to the store with her. Can you imagine? Going to Walmart?
Mm-hmm.
That's why we didn't do it, okay? Because it was an all-day affair. It took you 10 minutes to get inside the door. All right? Her ejection fraction was about 10%. It's a normal ejection fraction?
50%.
55%, right? So 55%. Yeah, I had to study for your test. But the 55%. So that would be the normal ejection fraction. So that's a chronic problem over time. And the acute CHF patient can have this due to an MI. You held that heart with that big old MI on it, right? You saw that dark spot on the heart, that necrotic tissue, that dead tissue. Okay? You saw that. You saw the surface area that it encompassed, okay, when you held that little heart. And so that is dead tissue. That dead tissue doesn't contract, correct? So what are you going to lose? Eventually, yes, you will lose output, but let's take it the first thing you're going to lose.
Strength.
Strength. Strength or
Force.
Starts with a C, the word I'm looking for.
Contraction.
contractility, right? Contractility. You're going to lose contractility, okay, which is going to lead to a decrease in output. The heart's not pumping as much, right? So it's going to eventually lead to a decrease in cardiac output. So that's the acute. That happens like right away. So all these signs and symptoms that we're going to talk about could happen within hours, okay? Or it can happen over a period of years, okay, with someone with CHF. Most everybody that has congestive heart failure, if something else doesn't take them out, CHF will. It's chronic. The heart is in failure, okay? Now, we're going to really, congestive heart failure, as you know because you've done your videos, right, can be complicated, right? It can be complicated with all the different pressures and everything like that, but we're going to try to make it simpler. There's no need to get really complicated where we are right now. Okay, we'll try to make it a little bit smaller than what it is, but there is more. Just remember, this is just an overview, right? Okay, so 2 more definitions. Preload. Preload is the volume entering the ventricles. Okay, I think that a better definition really is end diastolic volume. That's where I needed this space. Okay. End diastolic volume. Okay, so volume is the amount of blood, right? Because the blood doesn't stop, correct? The blood always enters the heart until the heart stops pumping. Okay, it always enters the heart. It's like traffic on 635. It never stops. Traffic keeps on going until it gets congested. Then once it gets congested, what happens to it? It slows down. And like this morning on Interstate 20, what's it do then? Stops, or
Extremely slow.
it gets real slow, and once it gets real slow, what happens to the traffic? Congested or backed up, right? It backs up. Like this morning, I turned around and looked in my mirror, and there was traffic stopped as far as you could see. And so it was backed up. Backed up is the word that we want to try to remember, okay? That when we think about CHF, you get a backup. All those cars have to go somewhere, okay? And in CHF, you get a backup because of a problem on the interstate. We get a backup with CHF because of a problem with the heart, right? Okay? So, let's look at this end diastolic volume a little bit, because it's time. No, not like it's time to do it. It's time, right? It's measured in time. Friday humor kills me. So you have a timeline here, okay? So you have contraction or systole, right? So you have systole here, and systole is over a period of time. Does everybody see this? Even though it's very quick, that bump is quick, okay? The contraction is very quick. If we have a heart rate of 60, this takes place every second, right? So we have a heart rate greater than 60, so it happens less than a second. So we have a period of time here of systole, whatever that time is, okay? And then what do we have after systole? Very good. We have diastole. So we have diastole here, and that goes for a period of time. And then what happens again? Systole. Right. But at the end here of diastole, we have something that's called an end diastolic volume. And that's the amount of blood in the ventricle at the end of diastole. So the end diastolic volume, the blood in the ventricle at the end of diastole. That sounds a lot like preload, right? Sorta? Mm-hmm. Okay. So if we have a decrease in end-diastolic volume, what are we going to have a decrease in? Well, okay,
Decrease in afterload?
stroke volume, but overall, very good cardiac output. So we're going to have a decrease in cardiac output. If something is hindering our pump, okay, and it doesn't squeeze hard enough, so loss in contractility, if it doesn't squeeze hard enough, we're going to have a decrease in cardiac output. That blood's going to stay there, right? It's not squeezing hard enough to get it out. Does everybody follow that? I know we're going sort of slow in these steps, but it's important to understand. So preload or end-diastolic volume, not necessarily the same, but think of it as sort of the same, okay, when we think about CHF. Afterload is I want to read the resistance that the ventricle has to overcome to circulate blood. So let me draw again. Okay, this is the aorta, right? Heart. So if you just took this part of it, it sort of looks like butt cheeks, but okay, it's a heart. Okay, so we always have blood in the aorta, correct? All right. So we have blood flow that's going down this way when it contracts, and then what does that do when it in diastole? So in systole it pushes blood out. What does it do in diastole? Very good. It backflows. It comes back this way, right? And that's where the coronary arteries are fed, is during diastole. So that backwash of the aorta, okay, gets here. So there's always blood in there. That's what I'm getting at. So when that ventricle contracts, that aortic valve opens due to pressure, okay, and then the left ventricle contracts, it has to push blood out into the aorta up against blood that's already there. So you can see the resistance, correct? There's a force there. There's a pressure there that it has to overcome, that the left ventricle has to overcome to get blood into the aorta. Everybody good with that? Mm-hmm. That's afterload. That's very important for later, especially to understand. Preload, afterload. Everybody good? So a couple definitions there. I don't trust the mouse. You won't need to take notes of this because it goes too fast, but I do want to.
Complications. Despite ongoing advances in the management of chronic heart failure, patient outcomes for acutely decompensated disease have not improved. Across Canada, patients hospitalized for heart failure continue to suffer frequent complications, and 16.5% die during their initial hospitalization. An examination of the pathophysiology of acute decompensated heart failure identifies promising new avenues for treatment. During heart failure, the heart cannot circulate enough blood with normal cardiac filling pressures to meet the metabolic needs of the brain, kidneys, heart, and maintain blood pressure, but over time, they cause heart failure to worsen. One of these neurohormones is renin, released by the kidneys in response to decreased perfusion and increased sympathetic activity. Renin activates the renin-angiotensin-aldosterone system, or RAAS, by cleaving angiotensinogen in the liver to produce angiotensin-1, which is further converted to angiotensin-2 in the lungs. Angiotensin-2 binds to blood vessel walls, causing vasoconstriction. Angiotensin-2 also stimulates release of endothelin from endothelial cells. Angiotensin II and endothelin act on vascular smooth muscle, causing constriction of the coronary arteries and systemic arteries and veins. While vasoconstriction helps maintain blood pressure, it can also have unadaptive effects. For example, the weakened heart must pump harder against increased resistance in the systemic arteries, while constriction of the coronary arteries further compromises the myocardium's supply of oxygen. Venous constriction also contributes to displacement of fluid into the lungs and other tissues. Angiotensin II stimulates the adrenal glands to release aldosterone. Aldosterone causes the kidneys to reabsorb sodium into the bloodstream, with it water. Sodium and water retention cause a state of fluid overload that is exacerbated by venous constriction. Gaseous exchange in the lungs is inhibited by pulmonary edema. Build-up of fluid in and around the lungs increases the physical work of breathing. Patients with acute left-sided heart failure feel short of breath and fatigued. When right-sided heart failure occurs, fluid accumulates in the liver and legs. Apart from the activity of the RAAS, the body tries to maintain blood pressure using other mechanisms, such as releasing epinephrine from the adrenal glands and norepinephrine from the sympathetic nerve endings. These catecholamines increase heart rate and contractility, in addition to causing arterial and venous constriction. Over time, chronic volume overload and the activity of angiotensin II, aldosterone and endothelin stimulate pathologic cardiac remodeling. The interstitial fibrosis and myocyte apoptosis associated with cardiac remodeling decrease heart wall elasticity, further inhibiting the heart's ability to relax and pump effectively. In summary, the neurohormonal response to heart failure causes vasoconstriction, fluid retention, and increased heart rate and contractility. In turn, these processes initiate a vicious cycle of further myocardial injury and escalating heart failure. Fortunately, additional neurohormonal responses modulate the activity of the RAAS, endothelin, epinephrine, and norepinephrine.
So that's a lot of stuff. Any questions? You guys got that? Yeah. You good with that? Okay. All right. Don't worry. You will understand 90% of that in April. Okay. So just hang on to it. What it went over in the RAAS is the renin angiotensin aldosterone system. Okay. Renin and angiotensin aldosterone system. What you need to know for that, just remember RAAS, okay, and that it's a kidney function, and that the RAAS helps regulate long-term blood pressure. Okay, short-term blood pressure, like the video said, is done off the adrenal glands through the sympathetic nervous system, through epinephrine, norepinephrine to increase heart rate. So short-term regulation of blood pressure is the sympathetic nervous system. Long-term regulation in fluid balance is through the kidneys. In speaking of fluid balance, we have these different pressures in these capillaries. In this here, we have these different pressures. All right. Right now, I just want you to be familiar with the terms. All right. I really don't. We really won't get into too much of the pressure, but hydrostatic pressure, hydro meaning what? Yeah, unless you're what was that show? The Shield. You remember? Did y'all watch Shield? Have you ever watched Shield? The Marvel?
Oh, the Shield.
Hell, hydro. What? Hydra. Now, okay, spoil the joke. Thank you. Okay. Yeah, blew that for me. Thank you. Hydra, right? Okay. So hydro, water. So we have pressure here. Okay. Water exerted against the blood vessels. Osmotic pressure is solution or solutes. Okay. So the way that I remember that from chemistry is that's the stuff, like glucose would be a solute, right? Okay, it's just the different things that are in the blood system, the solid things, right? Did I have that right? It's sort of the solid things? Okay. Of course, you have blood, plasma, exerting pressure against the wall. You have interstitial fluid. In the pressure, that is very low. Okay, let me laze it here. This would be, P2 would be the interstitial fluid, all right, in this particular drawing. You have colloids, which are plasma proteins, okay? Those proteins are used to pull and push fluid for fluid regulation, okay? So these big proteins help with somewhat with fluid regulation as well with the kidneys. Go ahead and thank me now that we're not going to dive deep into the renal system. You're welcome. But then interstitial fluid. This fluid moves in and out of the capillaries to create fluid balance, water-based and water-based balance with acids and water. Very complicated. It's not necessary for what we do. Okay. You will hopefully get into that in anatomy and physiology. If you don't, you will at a college level for sure. I don't know about where you are now. All right. So just be familiar with these different pressures because they are important. And don't look if you have a seizure. And we have these different fluid compartments, okay? So we're 40% solid. That's good to know. 60%, 55-60% fluid. We're water. Okay, we're made up of water. That's the importance of drinking a lot of water, is that we are made up of water. If we lose water, we have to replace the water. Okay? Intracellular fluid, that's fluid inside the cell. The fluid helps with pressure that's inside that cell. Extracellular, outside the cell. And then interstitial, 80%. So there's sort of the breakdown of the fluid compartments. Now back to this. So before we start talking about how this fluid moves, this is Starling's law of the capillary. Starling was this guy who came up with a lot of different things. This is only a section, so later in life, you don't think bad thoughts about me that we didn't go into all of Starling's law. It's actually fairly large and complicated. You don't have this in your notes, by the way. I only put this up there to show you the math. Okay, we're not going to do it, but tell your math teachers that, hey, learn a little math clinical today. But this is the flow. We have a tube, right? We have one end of the tube and the other end of the tube, which have different pressures. Pressures on the outside, pressures on the inside. So it does get rather complicated, but we're gonna make it a little simpler. Okay? So Starling, to keep it simple, right? The KISS principle. Okay? I call it my rubber band theory. So you have the heart here, you have a rubber band, right? And you have contraction of the heart. So what Starling said was the myocardial fibers are a lot like a rubber band. That this, if you stretch this rubber band and let it go, it's going to come back to its original origin, right? So I stretch it and let it go. It comes back to its original origin. If I was to shoot it across the room, it's stretched out right now, but once it lands, okay, it's going to come back to its original origin. So think about the heart now, okay? Think about the heart when we do this. So I have this rubber band, the ventricles, right? Love dub, love dub, love dub, love dub, love dub, ba-boom, ba-boom, ba-boom. Tachycardia, bradycardia, golfer's clap. Okay, so you have the heart that sits here and you're doing this, correct? So what Starling said, and it's a law, so it's reproducible, okay? Like the gas laws we have, they're reproducible. They happen all the time, the same way. So boom, boom, la da, ba boom, ba boom, ba boom. Okay? So according to Starling is that once this is stretched, when does it stretch? Very good, filled with blood. So it's going to stretch out. So it's going to stretch out. And according to Starling, okay, is that we stretch this out and it will come back to its original origin up to a point. Okay? The point would be if you overstretch it. If I overstretch this rubber band, according to his law, that eventually this rubber band is going to be overly stretched and it won't come back to its original origin. So this is what we have at the beginning, right? CHF, feeling. That's Friday. So now we have this. Okay, can you visualize the loss in contractility? We had this before, and now we have this. Okay? Because this is overstretched. The reason that it's overstretched is that it's in failure. Okay? And I use that term loosely. Okay? But it's in failure, so the heart's in failure, and it's overstretched. Because I don't know if you remember the first part of when we did our anatomy, is that I said the heart is a 4-chamber, 4-valve, 2-sided pump. Okay? So you have 2 sides to the pump. You have a right side pump and a left side pump. So you can have right side failure and you can have left side failure. Right side failure will lead to left side failure. Okay? But the pump is failing for some reason. Oh, maybe it's chronic. So over time, it's failing for some reason. Maybe it's an acute failure, like the person had a heart attack, the big one, okay? And it's failing, it's not stretching, it's overstretching because of or it loses contractility because of the MI. But we're going to talk about chronic. So over time, for some reason, this pump is now failing. Okay, so we have this failure in this pump. So we lose the contractility. When it when it stretches out, okay, originally, like our hearts will stretch out and they will come back to the origin because they're not overfilling. Filling, okay? They're not overfilling, okay? But someone in failure, that will, because the blood keeps coming, right? Just like the cars on the interstate, they keep coming, okay? So can't slow that down. So they keep coming and filling that ventricle, and it stretches it. Over a period of time, it's going to stretch it out, just like the rubber band, and it's not going to come back to the original origin. Is everybody good with that? Mm-hmm. Okay. So, right-sided failure, we're going to have a backup, correct? Because the blood is not going to be pumped through. There's this hypertrophic heart now, this stretched out heart, is not going to be able to come back to its original origin, so it's going to lose contractility. So we have this lack of pumping out, ejection fraction, okay? We have a decrease in ejection fraction because of the overstretching of the myocardium. So we have a backup somewhere because the blood keeps coming, so it's going to back up. So trace it out. On the right side of the heart, where's the backup going to go? What did you say?
The left side?
No, the right side. And let's say now we're
the body.
Huh?
The body.
The body. The patient's in right-sided failure. Now the backup is going to be in the body. So it's going to go right to the extremities, the vena cavas. It's going to back up, just like you have that big nasty wreck on the highway, and people start getting off the highways, right? And then the side streets back up. correct? Because all the cars keep coming, but they're going different directions. Now you have backup on the side streets. The same way in the body. Now you get back up into the small vessels, and you get back up into the periphery, the arms and the legs.
Is that going to cause inflammation?
Yeah, exactly. It's going to cause edema. So you're going to have edema in the lower extremities. So one sign of right-sided failure is peripheral edema. Everybody good? Okay, so you're going to have that swelling in there. Now let's talk about the other side. The left side. Now the left side failure. The left pump is failing. Okay. Where's the backup going to go?
Lungs.
Very good. It's going back up into the lungs. So you have pulmonary artery, right? Because you're going away from the heart. So pulmonary artery, arterial, capillary, correct? Now we come to this picture. The alveolus, all right, is the third pressure. You have the intravascular pressure, this capillary. You have a pressure in there, correct? We're not going to attach numbers to it. We're just going to say there's a pressure there. But now we have backup. We have a backup that's reached the capillary. Okay? So let me get my red pen. So I'll draw this as the backup. Now we have this backup. What has happened to the pressure in that capillary? It increased, right? So P1 has increased. Okay? We have P1 increased. Okay? If P1 is greater than P2, that almost sounds like math. I need to stop it. If P1 is greater than P2, where's the fluid going to go?
Down.
Huh?
P2.
To P2, right? It's going to come out of the capillary into the interstitial space. There is a space, there's a space of fluid in between this very thin fluid between the capillary in the alveolus. Okay? So now you have a higher pressure in P2. So at P2, the pressure in P2 is going up. Now if the pressure in P2 is greater than the pressure in P3, which is in the alveolus, where's the fluid going to go? You're right, exactly. It's going to go in here. Now you have pulmonary edema. You have fluid in the airway. If this continues to happen, it's unchecked and it's continued to happen, where's this fluid going to go?
Back to the heart.
Yeah, it's going to go out, right? So what's the next place it's going to go? Let's say it fills this alveolus. Where's it going to go now? The bronchial. Okay. To the bronchus. Then where? Trachea. Then where? You want to take those short steps? Yeah?
No.
Out, out. So you're going to have, don't worry, I have a picture. You're going to have this frothy pulmonary edema. I think it was this class that saw that. No? No, I have a picture. Okay. We will. So, anyway, one of the classes saw it during the CPR. So, anyway, so you have frothy pulmonary edema. Anyhow, so it will go out. Now this patient has fluid in their airways. So think about that. You have fluid in your airways. So you will have problem diffusing gases because that gas won't diffuse through this fluid. It's too thick. It's only designed to diffuse through the normal P2. I'm glad I put letters on that instead of numbers like the other day. It was confusing. But it only will diffuse through this thin layer. If you have an extra layer there, it won't go through. Okay? Does that make sense, everybody? Okay, so now you have fluid in the airways. And they can't diffuse, so what are they going to have? What's some signs and symptoms that they're going to have? Shortness of breath, increased work of breathing. They don't have to work to breathe, okay? What'd you say?
Their oxygen, it's gonna be below.
I don't know. I'm gonna have to think about that one. Decreased what though?
Partial
SpO2. Okay, what? What? Huh? Oh, I thought you had. What else? This patient has fluid in their lungs. They're here. What can't you do? But this patient has fluid in their lungs. They're here.
Oh, you can't do CPR.
Yeah, well, they can bend over. Huh? Yeah. Lay flat. Think of fluid here. Okay.
So then it just goes everywhere.
But if you go down here and fluid goes this direction, what's going to be the sensation that the patient feels?
Nausea.
Huh? Drowning.
Pressure, drowning.
They have fluid. Okay? They have fluid. So when you lay that person down, they're going to have the sensation that they're drowning. Okay? I don't know if you've ever had that sensation before, but it is frightening. Okay? So this patient, this CHF patient, will not allow you to lay them down. It's like waterboarding them. And I mean, it's going to be frightening for that patient. So that's an issue. Okay? Let's say that they do have this edema coming out of their mouth. What else is that going to produce? What problem is that?
Oh, they're gonna lose they're gonna be dehydrated.
Not the. What's the acute problem that they're going to have? They have sputum coming out of their mouth.
Can't breathe?
Well, it's an airway concern, right?
Mm-hmm.
So what do you need to do?
Oh, you're gonna clear their
Suction.
Yeah.
Remember, keep it simple. Right? You will have to suction them. Okay. So the need for oxygen. Do you think there's a need for oxygen? Yeah. Could be there a need for a bag valve mask?
Yes.
Right.
Definitely.
So you're looking at that bag valve mask. Okay. CPAP, which we haven't really talked too much about, that we will to get into CPAP. So they might need CPAP, continuous positive airway pressure, right? So let's look. So some of the signs and symptoms: mild to severe confusion, okay, anxiety, they're drowning, okay. So it would be the same for us. If you think you were drowning, then your anxiety level would go through the roof, right?
Mm-hmm.
Dyspnea, work of breathing, you can't lay them flat. JVD, extended neck veins, the backup in the vena cavas, right? The superior vena cavas, okay? This pink sputum, it's pink because it originally came from a capillary, right? So there was blood in it. Pressure's normal. This abnormal distension is called ascites. And thanks to Google yesterday, I learned how to spell it. Ascites, okay, is what happens with a lot of fluid. You have a lot of backup, right? So what happens with this fluid is it third spaces out into the abdominal cavity, and now you have fluid in the abdomen. Okay, it's not like trauma, like free-floating fluid. It's fluid that's third spaced out, but now it's made that abdomen very firm and tender. I've had several patients with ascites, and you palpate their abdomen, and it is tender, and it's swollen. It's very tender to the touch. Edema in the lower extremities. Don't worry, I have a picture. Shortness of breath, sweaty. The tripod position is the position that they bend over sort of and try to open up their thoracic cavity to get more air in. All right, that's for another day. We'll learn about that in sort of respiratory emergencies. CHF is a causes respiratory problems, but it's a cardiac emergency. That's important to remember. Rapid pulse, JVD, cyanosis very late, confusion during the hypoxia, lack of oxygen, right? So you can get that. One thing that the CHF patient has, okay, is that's common. All these are common with CHF patients are diabetes. That's the abbreviation for diabetes. Okay, they have hypertension typically. All right, and they're in this cardiac rhythm called atrial fibrillation. It's a very easy rhythm to interpret because it's irregular. It's regularly irregular. Okay, so it's an irregular rhythm. So when you have the CHF patient, you go and you do a radial pulse. It's probably going to be irregular if the patient's chronic. Okay, so they're probably going to have an irregular pulse. That might be normal for them. Okay, you hook them to a cardiac monitor and you see this. You can see where it's irregular, right? See the gaps here and the gaps here? Mm-hmm. It makes it irregular. The QRS complexes are not marching out, they're irregular. And the other thing that's very easy to identify AFib is because it's regularly irregular. Okay? Don't worry, when we get into EKG interpretation, that's a regularly irregular is a term. Okay? So it's an irregular rhythm, okay, and there's no discernible P waves. The problem that people have with interpretation of AFib is they try to put P waves there, and there's not P waves. Okay, there's not P waves. By definition, a P wave is upright, well-rounded. That's not so well-rounded. But upright, well-rounded, okay? Do you see anything in there that's upright, well-rounded, and regular? They look the same? No. Okay, so there's no discernible P waves in there, and it's irregular. So if you see a rhythm like this, and it's irregular, and you can't discern P waves, it's probably AFib. Okay, if it's a regular rhythm, is it AFib? Let's say you have a regular rhythm, okay? You have a regular rhythm, and you have all this in between. Is that AFib?
No.
Why not?
Because there's no gap.
It's regular, right? It's a regular rhythm. So this is what I term as crapocardia in here. This is artifact or something's wrong. If it's regular, it's not AFib if it's a regular rhythm. AFib is always irregular because the rules of interpretation, by definition, it's irregular, right? That makes sense? Now, the other thing is the CHF patient, due to the hypertension and the fibrillation of the atrium, there's this risk of stroke because of breaking off of the clots, the plaque and stuff in there, because the VFib, the heart sits there and does this, right? Mm-hmm. Okay, the ventricles, they're sitting there doing that. AFib, what do you think the atrium are doing? Because AFib, atrial, right?
It's the other way around, right?
The atrium are sitting there doing that. I had a really cool video and I lost it somewhere of this heart. They had an open heart surgery in the AFib. I'll try to find it. And you can just see the atrium doing this. Okay? The ventricles were pumping correctly, and the atrium were sitting up there fibrillating. Okay? So it's pretty neat. YouTube's pretty cool when we look at that. Okay, so this is very common. So diabetes, hypertension, AFib. When we get into the medicine part of this, this patient, the problem is you have to get rid of the fluid, okay? The excess fluid that's there. So this patient takes a diuretic. So medicine-wise, this CHF patient is going to take some form of diuretic. Since we're not into a big pharmacology part of it right now, one diuretic, sort of an old school diuretic, is called Lasix. Have you ever heard of that? Maybe grandma takes a water pill. You heard of they think, oh, I take a water pill. You heard that? Okay. So that's what some people call it. They say, oh, this is my water pill. What they mean is that pill is a diuretic. A diuretic will diurese. So what do you think that water pill is going to do? Huh? Produce water. It's going to make you go to the restroom very abruptly. When it kicks in, it's like, I gotta go now. Okay? So with that diuretic, with Lasix, however, with that diuretic, okay, it's also Lasix. Problem with Lasix is it's also going to take potassium with it. So CHF patients, they take maybe Lasix, let's say. Let's stick with the old school Lasix, okay? And then you will see a potassium supplement, because with all the urine and everything, it takes the potassium with it. It's not potassium sparing. They have potassium sparing diuretics now where the patient doesn't have to take an additional potassium, right? Okay. So, and then you'll see them with medication that ends with somewhere in their medication will be that glucose, right? They will take some form of diabetic medicine, which even if you don't know the hundreds of medications, you look for sort of the different suffixes, prefixes, or sort of a root of it, and you go, okay, this is a diabetic medicine. Then they'll take something for blood pressure. They may take the Lasix for blood pressure to get rid of extra fluid. Okay, I don't recommend it by any means, but some people take Lasix for a weight loss, so they can get rid of excess water. It's not healthy, by the way, because you lose potassium with it. One other thing before I break. This is the pulmonary edema, okay? Frothy pulmonary edema. Have you guys been to Starbucks and you got that cappuccino and they steam that milk on top of it?
Yeah.
You know what I'm saying?
No.
Yummy pulmonary edema.
No.
So every time that you take a drink of that Starbucks now, you think, oh, and it gets on your lips, and you're sitting there going, pulmonary edema.
No.
Love it. Yeah, yummy. Okay. So this patient is intubated, so they would need endotracheal suction. Without that, if they had that edema here, this frothy edema, then they would need suctioning, right? Okay. So maybe we'll go to Starbucks and we'll all get pulmonary edema. I'm cool with it. I drink it. Okay. And then you have cankles. You have the swelling. Okay. What's besides the ugly toes? What's the problem with these feet?
They're fat. They look swollen.
They're swollen. What's the problem with swelling?
That means it's where there's fluid accumulating.
Starts with the C. Huh? Circulation. Decreased circulation. They have a decrease in circulation down there. So that is a huge problem. It's very tender for them to walk on this. Okay. And then you have what's called pitting edema. And this is actually a test that you would do. You would push in and you would make a pit there. Okay. Sort of like someone took a sand wedge and they have a little divot there, you know. But they have a pit there. And we measure pitting edema, and there's a measurement there to figure out the severity of the edema.
What is that? That's somebody's leg? Or?
Yes, that's their bag. They have pitting edema.
If it's chronic, would they still have it like on an everyday basis, like painful sickness?
They could, yes.
So
But
like,
this is right-sided failure, okay? And then the pulmonary edema would be left-sided failure. Okay? Everybody good? Questions? Okay.